So Dr. Williams, welcome. How's your Friday going?
It's good. It's beautiful out. So I always love that.
It is gorgeous. It's gorgeous up here too. You're down in San Diego, not too far.
Yes. Yeah, not too far.
Okay. All right. Well, we're going to dive right in because we want to make sure that people who are working, who works on a Friday anymore, I don't know, but people that are working can get back to it. And we're going to be talking about PCOS. So let's dive in. What is PCOS?
Yeah, so PCOS stands for polycystic ovarian syndrome. It's actually the most common female reproductive disorder. So it's much more common than I think we used to think it is. It's really between 5 to 10% of women have this syndrome. And it's really characterized by cysts on your ovaries, elevated male hormones, which we'll call androgens, and irregular menstrual cycles. So that could look like long cycles, missing a cycle completely, spotting, just really irregular cycles. So that's typically what it's referring to when we talk about PCOS.
Okay. And you see women all the time, I see on your schedule, that have amenorrhea, which also falls into that category, right? What is amenorrhea for those who don't know?
Yeah, so amenorrhea is really just referring to when you have a lack of a menstrual cycle for over 3 months. And so there's a lot of different causes of that. PCOS might be one of them, but there could be other things like signaling issues with our brain happening, maybe lack of nutrition just causing the irregular cycle. So that takes further investigation and is why we do all the testing that we do.
Okay, but PCOS is a possibility with a lack of a menstrual cycle too. So it can be really long cycles. I saw a woman, last month, her cycle was like 38 days. So that would be inclusive of that. And sometimes they're irregular, but sometimes they can be regular, but long, right? So that's kind of deceiving where it's like, well, it's every 38 days, like on the dot.
Exactly. Yeah. I think that's really important to mention. So, essentially it adds up to what we classify oligomenorrhea as, which is one of the criteria for PCOS, is really less than 9 cycles a year. So even if your cycle is consistently regular at like 37 days, and it's always that way, that is still actually fitting into this criteria that you might have PCOS. So it's definitely worth looking into, especially if you have any of these other symptoms that we'll talk about today.
Okay. And so let's dive into the diagnostics a little bit more. So there is a criteria for diagnosis, and it looks different depending on the woman. So what is the exact criteria, and how can it present differently in different people?
Yeah, great question. So the criteria that we use right now is called the Rotterdam Criteria. So it's really broken down into 3 different components. And so in order to be diagnosed with PCOS, you have to have 2 of the 3. So one of those is the oligomenorrhea that we just talked about, those longer cycles that add up to being about less than nine cycles a year. And you typically will have lack of ovulation with that. The other one is hyperandrogenism, which is when we have elevated androgens, which can be, testosterone, DHEA. We'll talk about that more in a bit too. But those different androgens that typically cause the symptoms that we think of, like hirsutism, which is hair growth in places we don't want it. Chin, nipples, chest, and then we typically have hair loss on our scalp, and then typically acne, which is usually more so in the jawline area. So those are the main characteristics of having those high androgens. And then the last one is having polycystic ovaries found on a transvaginal ultrasound.
Okay. So somebody comes in and the 3 criteria that your OBGYN or your primary is looking for are the hyperandrogen, so high male hormones, lack of a cycle entirely or less than 9 cycles a year, or longer cycles, and then the polycystic ovaries on an ultrasound. But you only need 2 out of the 3, which means that there's a bunch of combinations that we could see within those, right? So you could have 2, but not the other one and still fit that criteria. Okay.
Yep, exactly.
Yeah. And I want to dive into that because I think that some people, it's really common in our practice to get a thin woman who has irregular cycles or doesn't have a cycle and does not have hair on her chin or does not have acne, But she actually still fits the criteria for PCOS once you do the full workup. So sometimes this looks a little different than you would expect, right?
Absolutely. Yeah. So it's really broken down into 4 different presentations, which I think is really helpful just to know which one you fall into. And that really also helps us dictate what treatment is best for you. So they've actually broken down into 4 different presentations, A, B, C, D. And so the first 2, A and B, are what we call more the classic presentations. Type A is the classic and really makes up about 60% of the population. So that's actually when you fit all 3 of the criteria that we were talking about. So since you fit all 3 of those criteria, you typically have the more severe presentation. So typically more weight gain, especially in the midsection, more of those androgenic symptoms. And then you're also more at risk for different metabolic diseases too, that we always want to be looking out for: cardiovascular disease, diabetes. So those are the things that we really find in that first group, especially. And often we'll see low progesterone too, because there's a lack of ovulation. So more menstrual irregularities is typically what falls into this group. And then the other ones get kind of less severe as we go throughout, but I think it's really important to think about, you might start out as a type A, the classic picture, but you can also move to some of these more mild, less severe pictures if we, find the right treatment for you and support your lifestyle and really, figure out the root and balance out your hormones.
Okay, that makes sense. And so type A means that you have delayed ovulation or no ovulation, or oligomenoria or no cycles, but you also have the high androgens or some symptoms of high androgens, and you have the polycystic ovaries on ultrasound. So you have like all 3
Exactly.
more severe, maybe more severe, but, and then the other ones are going to be classified into, you have 2 out of the 3, right? And like you can mix and match which of those are there, and that's going to change the symptoms based on that.
Exactly.
You glazed over something that I think is really important, which was the low progesterone piece. So can you talk about that a little bit? What does low progesterone have anything to do with PCOS? It's not part of the criteria, but.
Yeah, so low progesterone is what comes in typically after ovulation, and it helps to balance out our estrogen levels, and it helps with actually becoming pregnant and fertility. So it's a really important hormone that helps us with our normal menstrual cycles. So it's commonly low in PCOS because we're likely not ovulating. So it's really important to always be testing and looking at that too, and supporting that piece. It can be a really big, important piece of normalizing your cycles when we start treatment.
Okay. And so women may have symptoms of low progesterone with PCOS as well. What does that look like? Like what does it look like when progesterone is on the lower side?
Yeah, so really it can be a lot of fatigue, anxiety, depression. Those are very common. Sometimes even just more higher estrogen symptoms, which can be like breast tenderness, bloating, weight gain, more cranky, irritable. Those are some common signs of just not having enough progesterone. Even insomnia, that's a big one too.
I think we've talked about this on other podcasts, but I think of progesterone as like that calming sister that gives you a hug and settles you down. And then estrogen is like this like go-getter, boss babe, energy producing hormone that we have, which we need both of them in combo.
Yep. Yeah, the volume of our uterus is what I like to call it.
I love that. Volume of our uterus. I'm going to steal that.
Yes.
Okay, so we've talked about some of the symptoms with PCOS, but can you just give me like an example if you've, treated a patient recently with PCOS, like what do they look like? They come into your office, maybe what are they complaining of? What's the actual issue that they're having, or some different issues that they can have physically, how do they look commonly? And let's go from there.
Yeah, great question. I mean, the patient that comes to mind is actually someone I saw recently who, she had actually gotten off birth control a couple months prior, which can also be a big trigger because the birth control pill will just kind of mask the symptoms that you're having. And then when you get off, all of those things tend to flare again eventually. So that's what happened in this person. And she had gained weight like 20 pounds in 2 months. So that's a big indicator to me that fast weight gain that that is kind of out of nowhere, especially
Yeah.
if the patient didn't have, any changed with diet or exercise. So significant weight gain in a short period of time is a big one. And the androgenic symptoms are really big. Hair loss, hair growth, like I said, in places we don't want it, those are very common. So typically it's, overweight, hair growth coming out in places we don't like to see. Sometimes also that fatigue picture is very common. Even issues with becoming pregnant, and that's a big one too.
Okay. Okay. And where does the insulin resistance come to play in this whole picture? Because this is something in functional medicine we really focus on, and in conventional medicine, it's not as focused on typically.
Yeah, so it's really the primary driver behind PCOS. Insulin is actually what causes testosterone to increase further in our ovaries, and that's what causes this vicious cycle. So we really always want to be assessing the insulin picture as well. And so insulin in and of itself, if it's dysregulated and spiking after every meal or whatever that looks like, then a lot of times we do have a lot of fatigue with that.
Okay, so insulin resistance can look like fatigue after meals. I've also seen people with like skin tags from insulin
Mhm.
resistant, so that can be like a little sign
Yeah.
there.
Skin tags, even, I don't see this commonly in practice, but even like dark velvety skin patches like behind your neck and in creases, that can also be a sign too.
Darkening of the skin behind the neck, armpits sometimes will have the darkening of the skin with insulin resistance. And those are usually
Mhm.
more severe cases. Like you said, we don't typically see that. So if you don't have that, it doesn't mean you don't have insulin resistance, right?
Yeah.
And then there's that body type that's like super common with insulin resistance, which is around, like you said, around the midsection.
Mhm. Yep. But like you said too, I think it's really important to note there are many women who have a thin body build and still have a lot of these other symptoms and still have the PCOS picture. So you don't always have the weight gain. I think that's probably a genetic component too that plays a role with
Yeah.
how you present, but aren't necessarily always, having that significant weight gain or difficulty losing weight.
Right, right. Yeah. And that makes it so tricky too, right? Where it's not, I've had women that will come in and they say, my doctor said that there's no way it could be PCOS because they're thin, they don't have the typical presentation. But we can see it in thin women that don't look like they have insulin resistance. They may actually not have insulin resistance either, right? It doesn't have to be
Yeah.
the case.
Yep, it could just be a completely different presentation. That's why I think testing is so important and just really gathering that good intake so that we can figure out what's going on.
Okay, let's dive into testing then. And so we test everybody. So we're not going to just guess on this. You really shouldn't guess on this too. You want to get the testing done here. So what would you be testing your patients for if they came in with something that, is presenting like PCOS?
Yeah. So there's ideally two different sets of testing that we would like to do. The first set is on day 3 of your menstrual cycle. So day 1 is considered the first day of bleeding. So just 2 days after that. And we really want to look at your estrogen levels at the time. So estradiol, which is the main estrogen that our body makes. And that tells us a little bit about your ovarian and egg reserve. And then we also look at your LH and FSH. So that's your luteinizing hormone and follicular stimulating hormone. Those are two pituitary hormones that come from your brain and go down to signal to your ovaries to secrete hormones and ovulate. And so when we're looking at this ratio in PCOS, we're often seeing that our LH is higher than it should be. And so our LH to FSH ratio is driven up to about a 3-to-1 ratio, whereas normally it should be about a 1-to-1 or 2-to-1 ratio. So it's a really important marker for PCOS and tells us that there is likely an issue with ovulation going on.
Okay, beautiful. So day 3, first set of labs we're doing LH, FSH, estradiol, making sure that estrogen is where it should be, but also that LH to FSH ratio, which is that's a super important one, and I've found it to be really clinically helpful too. And sometimes you'll see labs from other doctors and they'll just be all the labs will be there, but you'll be like, what day of your cycle did you get this on? And they're like, I have no idea.
It happens all the time, like almost on a daily basis.
Yeah.
Yeah. So it's just not as helpful. But also, I mean, I guess another part of this too is with the PCOS picture, they might not be cycling, or their cycles might be so long, or they're not ovulating. So some of this might be hard to gauge at the right time. So we might not always be able to catch that time, but we do the best we can to get the
Okay.
most accurate information.
Yeah, and I want to circle back to that because we can use something to be helpful in that case of the anovulatory cycles. But let's first go to the second set of labs that we're going to be doing later in the cycle, and talk about that.
Yep. So the second set of labs is done around day 19 through 21 of your cycle. So that's about 5 to 7 days after ovulation. Once again, we'll have to time that out and figure out if that's even happening. But at this point is when it's really important to look at your progesterone levels. So we talked about that, really wanting to look at, are you making enough progesterone? Are you balancing out the estrogen levels? Is that also contributing to symptoms? Progesterone, if it's not high enough, can also contribute to further cyst formation. So that's really important to look at. But then also what we look at as well as all of your androgens. So this will look like your free and total testosterone levels. Also, DHT is an important one to look at, which stands for dihydrotestosterone. That's actually what testosterone gets converted to. It's the most potent form of testosterone. So we typically will look at those. And then androsterone, which is also another testosterone metabolite. All of those are very important to look at. Those are all coming from the ovaries, so it can give you all of those elevated testosterone symptoms. But another one that I always check, I think it's so important, is also your Dhea sulfate. And so this is still considered an androgen, but it's actually coming from our adrenal glands versus our ovaries, but can still cause a lot of the same symptoms. And so even just this one being elevated can still be a sign of PCOS. So that's why we really need to look at all of these to see, which are elevated and how we can support that specific, gland, either adrenals or ovaries. So I think it's really important to look at all of those. And like I said, even just one could be a sign of PCOS, but also none of them could be elevated, and you could still have all of those androgenic symptoms, and we still actually consider that PCOS, and you still fit the criteria.
Okay, that's really important. So you don't have to have elevated androgens on your lab. So testosterone could be normal. DHEA could be normal, but you have hair growth on your chin. You have those little usually coarse, darker hairs on the chin, chest or abdomen. We can see them in other places too, or acne or things like that. Signs of high androgens still qualify, not just labs.
Yeah, absolutely.
Okay, so that's day 19, 21. You're looking at progesterone. The other ones don't really matter when you're testing them, right? But we just lump them together. But also I think we want to point out, because like you said, women usually either have no cycles with PCOS or they can have a lot longer cycles. So we may change the timing not to be the 19 to 21 days, especially, if we're going to run the Dutch test too, we'll do this. But I'll use like the Opk Test Strips. Have you ever used those with women
all
with? Okay, let's talk about those.
Yeah. So Opk, absolutely. So those stand for Ovulation Predictor Kit. And so those are essentially test strips that you can get from like a local health food store, or Walgreens, CVS, things like that. And so you start testing it, at some point in your cycle, depending on when your last one was, essentially, and then you essentially urinate on a strip, and it will tell you if you are ovulating or not. So we have you do that for a certain period of time, and then once you get a positive ovulation test, then you time the blood work or testing 5 to 7 days after that. And also, if you do this for like maybe over 30 days straight and we have no ovulation positive test, then we just, would have you get blood work done at that point.
Yeah. So we're just going to run it because we don't have especially if you're not having a period, we don't have anything to go against. But I love the Opk test strips just to see, like, are you ovulating? And you may not ovulate every cycle. So just because you're not ovulating one cycle doesn't mean you're never ovulating. Some women will skip cycles, but they can be really useful, and you get them at CVS. It's like you can do this yourself just to see if you're ovulating throughout the month too, and when that is.
Yeah. Yeah, absolutely. And I love that you brought up the Dutch test too, because that's
Yeah.
definitely one of our favorite tests for looking at hormone metabolism. So that will give us a picture of your sex hormones like estrogen and progesterone. But the beauty of it too is that it will also look at all of your hormone metabolism and really dive into your testosterone metabolism, which is really important for PCOS. We actually get to look at your 5-alpha reductase activity, which is that enzyme that will kind of dictate if we're going to have more of those androgenic symptoms. So it gives us a really good picture of that. And then it also will look at your cortisol curve throughout the day, which we've talked a lot about that before in the past too. But cortisol is our stress hormone, which can also play a huge role with PCOS symptoms. So if our cortisol is imbalanced and elevated, which it often is in PCOS, then that increases insulin resistance further and also increase cyst formation.
Okay. Okay. So things get more complicated.
Yes.
But the Dutch looks at the cortisol curve, and that can like actually be a player in this whole PCS picture. And I love getting a cortisol curve on somebody, especially if they've never done it before, because you can time workouts around it. You can use it for different, just kind of personalization too. Awesome. Would you ever just do a Dutch on somebody, or are you usually doing blood work too?
With this picture, if I'm suspecting PCOS, I would really need to get other tests done. So that's really, we always need to look at blood sugar markers. So those are really important, and those are done through blood work. So, we need to be getting a fasting blood sugar, a HbA1c, which is your average blood sugar over the last 3 months, and then also a fasting insulin. So, those require beyond the Dutch.
Yeah, I totally agree. I like to get both of them. And I like measuring the androgens in the blood again, which I know you do too. Just because the Dutch isn't the best indicator for those androgen, like testosterone levels, but then you get the 5-alpha reductase, which I think is super helpful. And then you get the metabolites, which you don't get in the blood for the androgens too.
Exactly. Yeah.
We
I think
want
it's
it
good.
all.
Yes, we want it all. And, sometimes I even I'll start with the Dutch and then the next testing, do blood work. And so we get a lot of information that way and really stay on top of it with testing too, to make sure that things are improving.
Yeah. Yeah. And then there are some clients that don't have access to the blood work. And so sometimes you're like doing what you can do too, because it's better than nothing at all. So, sometimes, that's the only option is to do the Dutch.
Yeah.
Okay, so we talked about the Dutch, we talked about the cortisol curve, we talked about insulin. Where do you usually like to see insulin floating around, the fasting insulin level? Because the range on the labs is huge usually.
It's crazy. Yeah. So I think the range is about 26 or 27. And I really like to see it 7 or less.
Yeah.
That's really the goal. That's what is optimal. So yeah, much more narrow range there than what's given on conventional labs.
And there's so much that functional naturopathic medicine can do with an elevated fasting insulin level that conventional medicine doesn't really have access to too.
So much. I mean, this is where diet and exercise plays such a huge role. I mean, even just starting there can make a huge difference in insulin levels, which, since this is the main driver of PCOS, plays a role with everything else downstream, going to help lower your testosterone levels. So that's really the first place and something that we always want to work with.
Okay. Besides insulin resistance and the insulin labs, what other markers are you looking for with PCOS in terms of other hormones and inflammatory markers?
Yeah. So another hormone that we always want to look at is your thyroid. So we want to get a full thyroid panel to look at that, make sure that that's functioning well, because low thyroid function can also be a contributor to cysts and worsen insulin resistance, since it's a metabolic regulator. So we need to be looking at all of that to see if we need to support there as well. And then inflammatory markers, PCOS is inflammatory in nature with the insulin resistance occurring. So that's always good to look at too. The 2 main inflammatory markers that we look at are HSCRP, which stands for high sensitivity C-reactive protein, and then sedimentation rate, or ESR for short. So those are some of the inflammatory markers that we can look at as well.
All right. Any other labs that you usually run?
Ooh, I almost forgot one of my most important ones. Vitamin D is also a
Mm,
huge player with this. So there's actually great research directly correlating vitamin D to insulin resistance and inflammation and PCOS. So it's really important that we have an optimal vitamin D level, which I personally like around a 50 or higher. Not really any higher than about a 90, but in that sweet spot, 50 to 90 is really important to help support you as well.
beautiful, beautiful. We've got plenty of sun in SoCal, but we still see people with
All the
low
time.
vitamin D.
Yeah, I think it's really receptor defects, not being able to absorb it well enough. So it's much more common.
Yeah. Okay. Let's jump a little bit into treatment with the caveat that you are not going to treat everybody with PCOS the same, right? Which is
Yep.
important.
Like we talked about, there's so many different presentations. So it's going to be a unique protocol for everyone. But we do have a lot of great research for natural medications and therapies.
Yeah. Let's start with how does conventional medicine typically treat PCOS? What kind of options do they give for it?
Yeah, so the main therapies that conventional medicine gives is birth control. So like we mentioned earlier, it's pretty much going to be decreasing your symptoms through just masking your own hormone release and giving you that low dose of synthetic hormones. So it can be helpful in the short term, but it's really just a band-aid, unfortunately. So that's probably the biggest thing that we see being prescribed. And then the other ones that are really common too are metformin. That's a big one that helps with blood sugar regulation and decreasing insulin. So it can also help with weight management for that aspect as well. And then the last one conventionally, I would say probably the other most common one is spironolactone, which will help to lower your androgens, testosterone levels.
Yeah, yeah. And they work too. I want to point that out that in symptom reduction, spironolactone and metformin and birth control reduce symptoms a lot of the time.
Absolutely. Yep. I think it's just not always the best long-term solution. So
Yeah, yeah. So let's dive into that. If people want to, add things to their protocol or they're interested in functional medicine, like how does our treatment differ from conventional medicine? What additionals maybe we're talking about with people?
yeah, I mean, I would say one of the biggest things is looking at diet and lifestyle. So we really need to first and foremost work on blood sugar regulation and balancing out that insulin. So that looks like really investigating your diet, how we can support you there, making sure you're getting enough vegetables and fiber. That can be hugely important in just supporting weight management in general. What we've actually seen with women with PCOS is that a good goal to have for weight management is to get your abdominal circumference less than 35 inches. That really helps to reduce the severity of symptoms, because what happens unfortunately is that we get that weight gain from the initial insulin resistance, and then the weight gain further promotes more insulin resistance. So it's this vicious cycle. So we need to try to halt that, and diet and lifestyle really go a long way with that.
Okay. And then it also triggers the inflammatory response and it just like kind of becomes this
Yeah.
cycle.
Yep. More inflammation, more testosterone.
Yeah.
So yeah.
Okay. And often you'll see, so I like that you brought up a waist circumference of 35 or less, because in PCOS, sometimes we'll see this presentation of like this boxy look. So women are like missing the hourglass shape where they're not having the smaller area around their waist and then going back out to the hips. It's like a little bit more of like a testosterone picture where men don't have that either.
Yeah.
And so reducing that waist size, not so you're a Barbie, but just so that you have that silhouette shape, can actually help with the insulin resistance
Yep. Absolutely.
and cardiovascular disease risk, which you've brought up again too.
Mhm.
I always forget about that one with PCOS, that it is a factor that you have to think about.
Yeah. Yep. It is a big risk factor. Cardiovascular disease, diabetes, even sleep apnea too. So these are things to
Mm,
look out for, and even more reason to try to control and prevent this from happening.
okay, so if you're snoring, if you're waking up in the middle of the night gasping for air, your partner says you're snoring, something to look at is your sleep too.
Yeah.
Okay.
Absolutely.
And so with insulin resistance, diet, exercise, lifestyle, all the things that you said, avoiding sugar, like the obvious things there. But also we have we have like herbs and things that also work similar to metformin that we can use. Do you usually use compounds in addition to your treatment plans for PCOS?
I often do, just to really help decrease the symptoms and stop the cycle. So there's a lot of really great herbs and hacks to help manage blood sugar. I know berberine is probably one of our favorites for blood sugar regulation, and there's a really great research on it comparing it to metformin.
Okay. All right. I'm going to look up and see if anybody has questions at this point from our Instagram live. But I also want to thank you, Dr. Williams, for coming on today. Do you have anything that we
Of
didn't
course.
mention that you're like, this is such a clinical pearl, we've got to talk about it before we wrap up?
Oh, I think we covered a lot of it. I do. I think it's just really tailoring the treatment plan is really important because there's all those different ways it can present and, working on blood sugar, lowering androgens, adrenal support, like it can look like so many different things. So we need to figure out how to best support you and restore ovulation and get everything more balanced. But I think we talked about a lot of good stuff.
Okay. And I've seen your treatment plans before. And so I know that when you treat PCOS, you're using diet, exercise, lifestyle, but you have a ton of herbal options in your tool belt, as well as different nutrients that can help with insulin resistance. And then we call them biphasics, right, in naturopathic medicine, but different herbs that affect one part of the cycle versus
Yeah.
another.
Exactly. We can support the follicular phase and then the luteal phase, and that will restore ovulation and get things more balanced, get your cycle to be more around, 30 days versus 35 plus. So there really is a lot that we can do. I love herbs for hormone balancing, are so effective.
Okay. And we have one question, which would be a good one to wrap up with. She says, I have PCOS, but I'm skinny, good diet, exercise, no insulin resistance, no high blood sugar. Why do I have PCOS?
Oh, that is a good question. Skinny, good diet, exercise. So I guess my question would be if we have the high androgens going on, then I guess, and then maybe the polycystic ovaries. So I guess that would she'd probably have to have those two to even be able to have PCOS. But I think that it's hard to say why you might have it because the cause is really unknown. The biggest thing that we see is that there is a genetic component. So if your mom had it, you're more likely to have it as well. And then there was probably some other trigger in your lifestyle, stress, something like that maybe perpetuated that to happen. So not sure why you have it, but it sounds like you would probably have more of the high androgens and then the polycystic ovaries to actually qualify for having PCOS in that case.
Yeah. And I want to point out too, with, it's skinny, a good diet. So one thing that we didn't talk about is another test option, and that's a DEXA scan to look at body composition. You want to talk about that a little bit? Because I think that plays into this. Possibly, we don't know.
Yeah, so a DEXA scan is pretty much going to give us the breakdown, water weight, fat percentage, muscle percentage. So that can be a really good baseline test for us to do to look at where you're at. And then once we implement these strategies, we can really work to decrease your fat percentage is what we really work with. So that could be something worth looking into, even though you're skinny, maybe the fat percentage is maybe contributing to this picture as well and feeding into some of the symptoms that you're having.
Yeah, that skinny, we call it skinny fat, but just because somebody is thin doesn't mean their body composition is optimized. And so I always look, the DEXAs that I like have the visceral adipose tissue reading, the VAT, and that is fat around the abdomen. And so you could actually still not have that hourglass figure, or you still have a higher amount of body fat versus lean body mass, which can definitely contribute to insulin resistance as well as higher androgen levels too. And then you mentioned something else before for this person to consider, which would be cortisol curve or stress or inflammation, right? Which you don't really see necessarily.
Yeah, exactly. Like really looking at all of those things that we talked about and figuring out what is that missing puzzle piece to help support you.
Yeah.
Yeah.
Cool.
But I think it's really good, having a good diet and exercise is definitely the key piece of that. So we could always, see if there's anything else to dial in there, but really work on, some of these other strategies that can help support you.
Yep. And even when somebody has PCOS, but they're not exactly sure like how they got it, there's still so much we can do. So if you don't know the trigger, if it was genetic, or you don't have, diabetes or prediabetes or insulin resistance, it doesn't mean like you've hit the end of the road and there's nothing to do. There's still tons of herbs that can help regulate cycles. There's a lot of different options there.
Yeah, absolutely.
Okay. How do people find you?
Find me at Modern Med.
Yeah.
So yeah, you can find us on our website, modernmed.com. On Instagram, you can reach out. You can schedule a complimentary phone call, and we can touch base and talk about your health and go from there.
Awesome. Awesome. So Dr. Williams is based in San Diego, but she does a ton of mostly virtual consults with clients. In mine and Modern Med's Instagram page, there's a link to schedule a complimentary 15-minute phone consult with Dr. Williams. It's like a meet and greet. You want to ask her questions about, has she ever treated something like what you've been diagnosed with, or just to get to know her as a person, because it's so important to like and have a good vibe with your doctor. So that's available for you. And then email us at admin@modernmed.com with any questions. And I think we're good.
Absolutely. Yeah, I realized we didn't touch on the other question that we got though.
Oh, you're
about
right.
if you can still become pregnant if you have PCOS. And I think this is such an important thing, even though we talked about, yes, there are fertility issues. Yes, ovulation might not be happening, but you can absolutely still become pregnant having PCOS. It might be more difficult. We need to balance out your hormones and look into that further. But I've had so many women with PCOS become pregnant, all natural. And, sometimes might need a little bit more support, maybe some bioidentical progesterone to boost you and balance out your cycle. But it's absolutely possible. So I just wanted to touch on that.
Yeah, that's really important because we want to empower women to be, if you have PCOS, it does not mean you cannot get pregnant. I've had women with anovulatory, like no cycles, get pregnant. And so it is a total possibility to get pregnant, even if you have amenorrhea, but also just general PCOS. It's not a death sentence for having children by any means. There's so much you can do. And Dr. Williams also does a lot of preconceptive care in terms of like, how do you optimize your fertility, which is really just how do you optimize your total body wellness too.
Yep, absolutely. So,
all right.
perfect.
Well, thank you so much. I hope you have a good weekend. And we'll
you
talk to
too.
you soon.
Thanks for having me on. I'll see you soon. Bye.
Bye.